Hi, I'm going to talk about my opinion about how to treat younger adults with acute lymphoblastic leukemia. And based on the data that have emerged from groups all over the United States and throughout the world, there are emerging data that young adults with acute lymphoblastic leukemia have significantly improved survival rates when they are treated according to a pediatric intensive regimen. These regimens tend to have high doses or high intensity use of glucocorticoids, both dexamethasone and prednisone, frequent and long-term use of vincristine, and intensive use of pegylated asparaginase, along with frequent, early, and prolonged use of intrathecal therapy. With the use of these regimens, we've improved survival compared to historical controls from in the high 30 to 40% range, upwards of 70 to 80% overall survival using these pediatric regimens. Therefore, my belief is that any young adult up to the age of 40 and possibly even 50 years, since there are some trials intensifying treatment up to the age of 50, can safely and effectively be treated using a pediatric regimen. I think that it's still very important to treat ALL at a center that has expertise, because these regimens are very complicated. They take place or are administered over a very long period of time, years, and therefore you need a dedicated team of clinicians and practitioners to facilitate the treatment of the disease and to assist our patients to comply with these very rigorous regimens. In addition, I think it's particularly important for us to enroll our patients on clinical trials whenever possible, since the next generation of trials are going to be incorporating extraordinarily interesting and active new antibodies into frontline therapy to try to eradicate minimal residual disease, which has been shown to be an extraordinarily important outcome predictor. And to follow up on this idea, I think that when patients achieve a negative minimal residual disease status, that is, using sensitive flow cytometric or PCR or next generation PCR sequencing techniques, you can no longer detect any evidence of acute lymphoblastic leukemia within the first 16 weeks of therapy. Those patients have an extraordinarily good outcome. And even when you look at that, you can say, well, then maybe I don't need to transplant this patient. And in fact, that is probably the case. And even with just the intensive pediatric regimens, when they've been looked at in comparison to allogeneic transplant in first remission, the pediatric regimens win out in terms of a significant improvement in event-free survival, in part because of the high morbidity and mortality associated with allogeneic transplant. Therefore, at the moment, except for certain cases with high levels of minimal residual disease, I don't advocate and would not recommend an allogeneic transplant in first remission. For those patients with high MRD levels, transplant is a reasonable option. They do seem to have a better survival rate from a number of studies than if they're not transplanted, but I believe we can do better, and that's why I'm encouraging everyone, if it's at all possible, to enroll on the next generation of clinical trials in the US intergroup, where the new antibodies are being incorporated into frontline therapy. Thanks very much.